Good afternoon, everyone. Thanks for joining us today. I'm really excited for the conversation that we're going to be having today about a topic that I think a lot of families don't hear enough about or get enough information about, which is why we are bringing it today to the DEE community, which is about complex continual care for children and frankly anyone living with complex medical conditions. And for the developmental and epileptic encephalopathy community, we feel that there's probably a lot of families who don't know about this, and we want to shed a little light on it for folks, especially since it's Hospice Awareness Month. So for anyone who doesn't know me, I'm Gabby Conaker. I am co-founder of the International SCN8A Alliance and Deep Connections. And I'm here today with two fantastic guests who are going to shed a little bit more light on this process of, well, not the process, but the world of complex continuous care for families. So Tara Hoyt is the Executive Director of Capital Caring Kids, which is a regional pediatric, palliative, and hospice organization serving Southern Maryland, DC, and Northern Virginia. Tara is a certified children's grief counselor, end-of-life nursing education consortium pediatric trainer, and has 12 years of children's hospice program development experience. She lives in Virginia with her husband and two college kids. And in her spare time, she gardens and performs improvisational acting, which I want to hear more about soon. And full disclosure, Capital Caring is the pediatric hospice that my son Elliot has been enrolled in for, I think it's 6 years, over 6 years, maybe 7 years now. And we also have with us Terry Pratt, who is retired, but brings with her 34 and a half years of federal experience, federal service, excuse me, with over 20 years of those in management. She has over 10 years with Social Security Administration, worked in the Division of International Operations and the balance with Centers for Medicare and Medicaid Services, which are critical to this, to the kind of care that we're talking about today. And has done some specialization with state government officials, advocacy organizations, and provider organizations to help unique and innovative Medicaid, long-term care programs for our nation's most vulnerable populations, and includes home and community-based service waivers, the program of all-inclusive care for the elderly, which is called PACE, Hospice, and the CHI program of the all-inclusive coordinated care for children, ChiPACC, which you'll hear a bit more today. She's currently an active member of the board for CHI, board of directors, and you can tell that these folks are bringing with them a lot of experience, heavy hitters who are going to be giving us some more information about how hospice care, which is that's a term that's kind of falling out of favor, right? Hospice is a loaded term for a lot of people. I know hospice is something that I've experienced with grandparents, and I think a lot of people think of it as for older folks, end of life care. But pediatric hospice is a whole other ball game. And, we had another family speaker who was lined to come up, but life happens, as we know, for these families. So I'm just going to briefly share a little bit about my experience as a user of the care that comes with palliative services. And my son Elliot, who is now 9, was enrolled in hospice about 7 years ago. And it came to us at a point when we were fearful that we were going to lose Elliot potentially. His care was becoming much more complex. There were more machines, there were more drugs, there were more interventions. And when the idea of hospice was brought up to us, we recoiled. We said, oh, no, we're not there yet. We don't want that. We want Elliot. He's going to stay with us. We're going to fight for him as long as he can. And I'm so glad that we were talked down off of that ledge, because this is not about, it's not only about, I'll say, planning for end of life and comfort at the end of life. It is also very much about maximizing the life that our children have now um, ensuring that there's quality of life, giving families opportunities to explore different options. And I will be very frank that having hospice care, having this, coordinated care that has been provided through our through Capital Caring has allowed us to stay out of the hospital time and time again. When we're in crisis at 3 a.m. and don't know what to do, we always have somebody we can call. We have a nurse, a registered nurse who can come to the house, assess, help us walk through options, get us the critical drugs we need, get us the morphine, get us whatever we need to stay home and stay comfortable and keep Elliot as comfortable as possible. And I think for most of us, we do everything we can to stay out of the hospital. We know hospitals inside and out. We have our own, critical care units here at home with the machines and the drugs and the everything you can do, in our home, apart from, really high flow oxygen, IV meds, that we have everything else. And so we work to stay away from where other germs are, and it has been a lifesaver for us on so many levels. It has made our life easier. It has made our life more comfortable. We feel we have access 24/7 to people who can talk us through whatever challenges we're facing at that time, to counsel us on different options, to help us find our way through complex situations like signing up for CBD or for we've been counseled on planning for a funeral. We wanted to do that in advance, and so that was something that hospice was able to help us think through and get resources for. Managing our very complex medications, helping us get refills and following up with pharmacies. I mean, families like ours spend a really outrageous number of hours fighting with insurance companies and pharmacies and all of that. And those are some of the things that the burdens that have been relieved. And frankly, it's also a resource for the whole family. It's not just about making sure that the child who has, a severe health condition is taken care of. There are, and you'll hear more about this from Tara, but there are counselors that are available, social workers. There are volunteers that bring gifts and thoughtful, things for the family, not just for Elliot, but also for his little sister or for us. And it's really an all-round opportunity to get additional support in your life. And, really from the beginning, when there's a diagnosis, all the way through. And I think that one of the most critical things to recognize about pediatric hospice is that this is a service that is available from diagnosis through to curative, options. Elliot has a DNR, a do not resuscitate on file, but we don't plan on invoking it anytime soon. We are very actively looking at opportunities to give him treatments that will help him. And, maybe someday we will be able to come out of hospice care with a healthier kid. And I know that that's the goal of everybody who's working in this space, is to keep families and these children as healthy and happy and comfortable as possible. And so I could go on for a really long time. I'm going to stop there because I can keep preaching about it, but I want you all to hear a bit more about the practicalities, the intricacies. Tara's going to walk us through a bit more of what it looks like to enroll in a program, what kind of services you get. And then Terry's going to take us through a little bit more of the bigger picture. Children's Hospice International is a global program, and we believe very strongly in access for anyone and everyone in these situations to get that kind of care. So she's going to talk a little bit more about the advocacy side and the global elements of it. So Tara, I'm going to hand it over to you, And as you're pulling up your slides, I welcome folks, as you think of them, to put your questions in the Q&A, and we will have plenty of time at the end to kind of dig into more of the details.
Good afternoon, everyone. For those of you who are with us live, and also those of you who will be watching this maybe at 1 a.m. after you've tucked your child in. I really could not have asked for a better introduction from Gabby about what Capital Caring Kids is, who we are, how we work. Elliot is a very special patient of ours because he is the patient who's been on service the longest. He has had so many different iterations of his illness. He's been on a roller coaster, to say the least. And we've been there to walk alongside the Conakers as they have cared for him. And we're so honored to do that. And we're also honored to talk to any of you with children who are experiencing complex illness to sort of demystify what hospice really means and how to access the care. So I want to start out first by saying that this is our why right here. These are a couple of pictures of some children we've cared for, including Elliot down here at the bottom with his mom several years ago. And this is a really important part of the care that we provide. We understand that every child is precious and every moment with them matters, and every child has their individual story, their own family, their own set of standards and cultural beliefs and all of those things that make up the whole child and the whole family. So we serve children from before birth, actually, until the age of 21 with life-limiting medical conditions. We understand that children and teens really require a specially tailored approach for compassionate care. And I'll get into what our care looks like at each phase as I go through the presentation. But we provide holistic symptom-directed care encompassing the social, emotional, psychological, and spiritual needs of children facing serious illness wherever they call home, anytime, day or night, as Gabby said. So we also provide palliative care, which is basically a lighter level of care than hospice, and I'll get into that more later as well. And really, we work with the whole family to create meaning for the child and the whole family, no matter how long they're with us. So this is a list of the services that we provide. So perinatal palliative care, and typically what that means is when a maternal fetal specialist has reached out to a family, or when a specialist at a children's hospital has identified a need for a family who is expecting a very complex ill child, we are available for consultation, and also our social workers and counselors are available to talk to the families, to talk about the diagnosis, explore different options, help them research the condition, and actually create a birth plan if they would like to do so. And some of our team members have actually been in the labor and delivery room when some of these babies have been delivered. And while some of them are only with us for a couple of minutes or hours, some of them wind up coming home on our service. And we've even had 2 children over the last 2 years graduate from hospice completely, defying all the odds. And that's always what we're hoping for any child and family that we're taking care of. And our palliative care is really more of a nurse practitioner following the child's case, visiting once a month, along with a social worker and child life specialist who make sure that the family is connected to resources within the community. And we also do a lot of complex care coordination, collaborating with the children's specialists. Concurrent care, otherwise known as hospice care for us, is a much more expansive service, and it's what Gabby's family has, which is a 24-hour access to a pediatric physician, hospice physician, nurses, hospice aides, social workers, child life specialists, and chaplains. And we do a considerable amount of care coordination, actually on a weekly basis, for these children to make sure that they have access to all of the curative and disease-directed treatments available to them, as well as us as an added layer of support at home. And then we also provide grief and bereavement support, not only to the families of pediatric hospice patients we've served, but also to anyone in the community struggling with loss. We care for many, many children throughout our region who've lost parents, grandparents who have been raising them. And right now, the need is amazingly great, as you can imagine, with the number of COVID losses. So we provide bereavement camps every year and several workshops throughout the year for not only our own families we've served through hospice, but the community, like I said. A lot of the things that we do throughout these different services is discharge planning for perinatal all the way through hospice care, because as you can imagine, children go in and out of the hospital. We try to avoid that as much as possible, but there are times when they need to be seen by their specialists and need a little touch up, if you will. And so we do all of the management for the discharge planning, provider consultation and guidance, and also approaching difficult conversations with parents and also providers. So we came up with this graphic, which sort of explains concurrent care a little bit. If you're not aware of concurrent care, you haven't had any experience with it, this might just look like a series of blobs on a screen. But if you can see here, we start out with a serious illness diagnosis. So this is that moment that each one of you has experienced, that sick feeling that you hear when you hear that your child has a very serious illness that is going to be life-limiting and impact the whole family. And so, of course, that usually sets families on a course towards disease-directed therapies. And at that moment, that is when hospice and palliative care can be considered. And I know that sounds crazy because you think, oh, well, the word hospice means the last few days of life. And like Gabby said, it means that someone's 98 and they're taking their final breaths. And throughout this presentation, I will show you that it means much more than that. And then the journey continues. And sometimes this can actually become a circle where we have children who are still receiving disease-directed therapies. They come onto hospice service, then they improve and they go back down to our palliative care service, and sometimes off. So that's why I think this graphic is really helpful. So concurrent care really is legislation that was passed back in 2010 through the Affordable Care Act in Section 2302. I told my team when we first started really caring for kids, I was going to get them t-shirts made with 2302 on it, because I wanted everyone to never say no to anything. When a pediatric hospice family asked us to do something, I'd say no. If there's something difficult that's outside of our scope of services related to comfort, we'll figure out how to get that child what they need at home. So essentially what it means is that for children who have a life expectancy of 6 months or less, and I will talk more about that later, they are eligible to receive hospice care and disease-directed therapies. So what that means is you do not need to stop any treatments for your child that you're already doing and pursuing for that child. And you can elect hospice benefits that is paid for by your insurance company, including Medicaid, to provide that hospice layer of support at home. So a lot of people are surprised that they can have this service, and a lot of people miss out because providers are unaware of that. The hospital system is sort of stuck in their own mind that they can do all the things that need to be done. And they think if they send you home with private duty nursing, then what else could you possibly need? Well, we know that caring for a sick child is way more than just medications and the right kind of bed. It's about your spiritual, emotional, and your whole life, really. And so as a nonprofit, Capital Caring Kids is committed to caring for all children. And if they do not have insurance or don't have enough insurance, we provide that care as a charity. Last year, we gave $3.3 million worth of charity care away as an organization. And I'm happy to say, though, that for most kids, we are able to find insurance for them, and that's part of our advocacy. So really what concurrent care is all about is improving the quality of life for the child to decrease your patient costs, so decrease those hospitalizations going in and out of the hospital, and decreasing the stress of parents like Gabby, and not having to worry about every little thing once you're at home. And also increasing the likelihood of dying at home should that be the choice that the family makes. So pediatric palliative care really recognizes that every child deserves a childhood. And one of the things that Gabby talked about was not only do we provide a physician and a nurse, a social worker, and a chaplain, but we also provide art therapy, play therapy, volunteers who can do everything from even giving haircuts. And I hope Gabby doesn't mind me bringing this up. I wish I had the picture here with me, but Elliot had not had a haircut in like 4 years, because how are you going to get him out of the house to go get a haircut? That is the last thing on Gabby's mind. So we had an amazing volunteer who came not only to do a haircut for Elliot, but do a haircut for the entire family. And it was such a wonderful night because I feel like the whole family felt nurtured and cared for. And it was provided completely for free. And that's just a little example of some of the things that we do to care for the whole family. So of course, we provide expert child and family-centered care, and we understand the challenges that are faced by families like yours. And we also understand the stress on siblings when they're watching their sibling struggle, and they're watching parents struggle to meet all of those needs. So for Capital Caring Kids, this means that we admit any child with a life-limiting prognosis who is receiving treatment still, or maybe the family has decided that just comfort measures are what they want to pursue for their child. We follow along with whatever the family's goals of care are. And we create a plan of care from those goals of care, and we share that with the child's providers, whether they are their GI specialists, their neurologists, their palliative care docs at the local children's hospitals. We collaborate very closely with them. So capital caring is paid on a daily basis, called a per diem, by the insurance companies. And this is the little moment where I'm going to talk about the insurance piece, because when I first became director back in 2018, we were caring for kids along with adults as an organization, but we were just only caring for children who really were comfort only. And we were getting these kids referred to us in the final hours of their life. And when we decided that we really wanted to open this up and follow the legislation of concurrent care, we had to really carve some paths, new paths with these insurance companies. We had to help them understand concurrent care legislation and how the bill was going to be paid. So I'll give you a great example. So a child is coming home from the hospital, and all of the treatments that they were pursuing are still ongoing. And so they want to come home and they need a BiPAP machine. Well, ordinarily, the insurance company would just pay for that, and that would be fine. But then when we add hospice to that, some insurance companies said, well, we're either doing hospice or we're going to keep continuing to keep this child alive. And so we've had to have discussions with case managers to say, no, that child is eligible to receive both that BiPAP machine paid for through their primary insurance and pay the per diem for hospice. So I hope that's helps a little bit to understand that. And Terry and I were speaking before we started our presentation. She's had many, many years with CMS and understands that system far more than we do. But on the ground here, as providers of this care, we have really had to school them or educate them on concurrent care and how these children are eligible for these services. And we've gone so far as to meeting with the different Medicaid directors in the different regions and having them be part of some of our care conferences with parents and providers. And it's been really exciting to see that sea change for how hospice and palliative care is perceived in Medicaid. So I will let Terry talk more about that, but I just wanted to share that that's one of the biggest pieces of work that we've done as a team over the last few years. And we're very, very proud of that work to advocate for our kids. So we, as I said, we keep in close contact with our insurers. And when a child goes back into the hospital, we discharge them from hospice service if it's over 48 hours. And then if they stay in the hospital for longer than 2 days, then we discharge them and bring them back on. And it's kind of a mess when we have to readmit a child. We have to do a whole start of care visit, which Gabby knows is about a 4-hour visit. It's kind of a big deal, but we do it because we want to make sure that the child's insurance does not have any lapses. So one of the reasons why concurrent care is not elected right off the bat is that a lot of providers don't know anything about it, and parents don't know anything about it, because certainly when you have a child who's sick and you're fighting for everything you can get for your child and pursuing all different treatments, including green tea extract or CBD, the last thing you're doing is searching hospice in the middle of the night, because hospice has that connotation of being what you do at the very end when your child is really nearing end of life. And so we understand that there is this huge black hole of information out there about hospice, and we're trying to change that, which is why we work so closely with Children's National and Inova and the other hospitals in our region to educate them on how a child is eligible really upon diagnosis. And once they find that out, they are so excited and they send us way too many kids. And we're like, wait a minute. We need to talk about each one of these children and make sure that they're really, truly eligible. And we'll talk more about that in a minute. So we also understand that pediatric specialists form deep, deep bonds with their patients and families. And what's so great about concurrent care is that they don't have to give that up. We're just an added component to that. So, and then we build a relationship with those providers as well. And we know that, that we can provide care at home that providers just simply cannot do in the hospital setting. And then there's also the misunderstanding for reimbursement allowances. Like I said, even insurance companies not understanding their own policies regarding hospice for children. So I could go on and on about more of the barriers for children and families for concurrent care, but what I really want to focus on today is how to get through those and how this might be beneficial to you and your family. So the benefits of concurrent care obviously are wraparound services that we provide for children with incurable conditions. We have a community-based team and it's full of resources. And even though the children are pursuing a cure, they are able to still have us be part of their team. So we are experts in children's pain and symptom management. And I think that's one of the biggest benefits, especially in the middle of the night, when your child is experiencing breathlessness or suddenly the medications just don't seem to be working. We have 2 pediatricians who are willing to hop on the phone with you in the middle of the night and get those medications out to you to keep you from having to go to the hospital. But also they have enough discernment to know when it's time to call 911 and go ahead and get the child into a hospital setting to make sure that those symptoms are being managed. We're also, of course, like I said, a liaison between the medical specialists and the parents. So when is it a good time to elect concurrent care for your child? We know that that is an individual question for each one of you, but really it is based on whether or not your child would, let's say this, would we be surprised if your child was still with us if all interventions in an untreated course of illness progressed? And that's a hard question to ask, but it's something that, you know, we can help families determine for their own child and also help providers determine. We have noticed that concurrent care has really modified the course for a lot of kids and extended their lives in a way that brings meaning and quality of life in ways that we couldn't even imagine. Because of that care coordination, I think that's the main piece, and then having that 24-hour access to our support. So one of the questions that we also have parents ask is each day a greater blessing or a burden for my child? And we can help sort through the answer to those questions. I just want to check the time. I can't see the time right now. Gabby, can you tell me?
Yeah, can you take like 5 more minutes?
5 more minutes, sounds good. Okay, so one of the things that Gabby talked about was trying to figure out what are the indicators for disease progression. Now, this isn't necessarily related only to DEE patients, but it may have some components that match for you. So it's essentially loss of function, neurodegeneration, increasing seizure meds needs, progressive heart or renal failure without transplantation option, even if they're on the list for that, failure to respond to chemo, relapse with high risk for incurability, failed stem cell transplantation, progressive weight loss, increased need for respiratory support. So, and then we have listed by system the different, signs that there's disease progression. And I will let you read that on your own. So another question that Gabby asked us to talk about is, how do we bring this up to our specialists? How do we as parents advocate for our children and say, hey, I heard about hospice care or concurrent care. Is this something that you believe would be a good fit for us? And I think sort of arming yourself with that list that we just went over and matching it to your child and saying, okay, you know what, there are some things on this list that I'm seeing. I'm seeing that, he's sleeping more, or we're having an increased O2 hunger, especially at night, or, he's having more bad days than good days, or, she's no longer able to enjoy school or her friends anymore. And oh my gosh, our family's really starting to wear out. Those are all the things that you can write down and talk to your provider about and say, I think that we need more help at home. And I heard that we can get that through hospice. And some of you may hit a wall with a provider who will say something like, well, oh my gosh, we can't, he's not hospice ready. And you may have to be the one that describes what hospice care really is with concurrent care. So that's what we're arming you with today. So another list of guidelines for concurrent hospice care are multiple trips to the doctor, to ER, for hospitalizations, lack of response to treatment or worsening symptoms. The treatment is having a negative impact on the quality of life. They're sick all the time. And actually, even if the chemo is shrinking the tumor or the new seizure med is controlling the majority of the seizures, but they're knocked out all the time, that's not a quality life for a child. Unintended weight loss, decrease in cognitive abilities, and the patient or the family desires comfort care. So we're always available to offer guidance and consultation for any child, even if a referral is not indicated by your provider or you decide to make another decision in another direction. So inside this presentation that Gabby is going to provide to all of you is details about what palliative care looks like from Capital Caring Kids, what hospice care looks like, and what our bereavement care looks like. So I did mention briefly that our palliative care service is more, it's sort of, we call it hospice light. So it is a nurse practitioner and social worker who visit about once a month and do some care coordination and can prescribe medications. Our hospice care is really where you get the significant complex services. We pay for all of the medications, all of the equipment in addition to the team that I mentioned already to you. And we will provide support to families for as long as it takes for bereavement, including anticipatory grief and loss that happens when you're facing a child's serious illness. Another thing that I forgot to mention is that we do have inpatient hospice care. It's very limited for us right now. We have 2 inpatient units where we can provide care to children. And that's when their pain and symptom needs go way beyond what can be managed at home. And usually we can provide that short term. We can also provide respite care at our inpatient units on a case-by-case basis. This is something that we're working on to expand in 2022. COVID really made it difficult for us to have enough staffing for our inpatient units and to get training to all of them for peds. One other thing I want to mention as well is that I mentioned that we collaborate very closely with outside providers, and we have our own pediatric interdisciplinary group meeting every 2 weeks where our social workers, chaplains, physicians, and nurses all get together and talk about each child. but we also have what we have called virtual pediatric consultative rounds with Children's National and Nova Children's, and also a VCU in Richmond, and occasionally with UVA to discuss children. We provide them with a synopsis of each child that we share and discuss those cases together. And that is where we believe we have made the biggest impact for children who are on service for us. Just making sure that we're all on the same page with goals of care and that we're managing everything the child needs, including their disease-directed treatments. So like I said, I could also go on all day and talk to you about what we do. And I hope that I've hit enough points that you understand that concurrent care really is a game changer for families like yours. And we're always here to talk to you about what that care would look like. Even if you don't live in our region, we can connect you with pediatric hospices in your neighborhood. Thank you so much.
Thank you, Tara. It was fantastic. I mean, so much packed in there. And we, like Tara said, we'll provide these slides so everybody can get a peek at all the information. Terry, I'm going to invite you to hop on and share a bit about the work you're doing and some more guidance for families.
All right, let me share my screen, get us going here. All right. All right. Well, welcome everyone. It is truly a pleasure to be here this afternoon to talk about work that's being done by Children's Hospice International, directly related to the work that you heard Tara talk about that's happening with her team at Capital Caring Kids. I'd like to start, though, by sort of sharing with you, who are we?
And Terry, just to start, your camera went off. I don't know if you meant to do that, but we can't see you. We'd love to.
I'm okay with that. It actually gives me a better view of my screen.
Aha, okay.
Thank you. Children's Hospice International was actually a concept that was conceived by Anne Armstrong Daly back in, believe it or not, 1977. And during that particular time, what she felt needed to be done was to have the ability for families with critically ill children to have access to both palliative and curative and hospice care at the same time. In 1977, there were no hospices in the world. And it's important to note that Children's Hospice International really is intended to have an impact and to recognize the needs of these children and families throughout the world. So in 1983, Children's Hospice International was incorporated. And at that time, just a few years after the idea sort of percolated in Anne's brain, there were at that time 1,400 hospices in the United States. Of those 1,400, only 4 were able to accept children as part of their programs. So thanks in large part to efforts of providers and advocacy groups and families, life has changed for the provision of services for these families and their children. But we still have a way to go. So 38 years later, here we are. And it's interesting that we've had this conversation about our use of the word hospice. And it does come with connotations because it was born out of the treatment, as we mentioned earlier, end-of-life care for seniors, both in Medicare and Medicaid. Children's Hospice International actually struggled with their name having the word hospice in it, even as early as 1983. And it, in some regards, felt to them to be contradiction to who we are and what our name says. But what they found in looking at the acronym CHI, Children's Hospice International, in ancient Chinese, it means life force. And in Greek, it means Christ, and in Hebrew, it meant life. When they looked at those concepts and that this word had meaning across these other cultures, it made them more comfortable that the values that they were hoping to share and move forward with were consistent with having a name, Chi, and keeping hospice in the title. That was important to Anne at that time. She really did struggle with that. The actual goal, the ultimate goal of Children's Hospice International, and it's on this slide, and I'm going to take a moment to read it, is to so ingrain the hospice palliative care concept into pediatrics that it is considered an integral part of healthcare for children and adolescents rather than a separate specialty. And we know, because the most critical time for children and family members when they need the intensive support and guidance that hospice and palliative care programs provide is at the point of diagnosis. Children diagnosed with serious illnesses such as muscular dystrophy or cystic fibrosis, they can live long past a 6-month window, but they can face a life-threatening situation every single day. They may also find it necessary to be in and out of terminal phases, and this affects the entire family. So there is a desire by Children's Hospice International and the work that they were doing and their conversations globally to recognize that you could not just provide care for a child with a life-threatening illness, but you had to recognize the impact on the family as well. So what do? We, in 1983, actually came up with, in coordination with JACO, which is the Joint Accreditation, the Joint Commission on Accreditation of Healthcare Organizations, a definition of children's hospice and palliative care. Prior to that date, there wasn't a standardization or even an attempt for that to occur. There are a glossary of terms that were developed in 1985. And they even went so far in 1990 to develop standards of children's hospice and palliative care for providing services to these children and their families. Education and training.
Sorry, could you say that again?
Oops,
My apologies.
That was me hitting my phone. Education and training, not limited to domestic, but also across the world. Technical assistance provided as of this date to over 60 countries, including the United States. And what that looks like includes not just provider organizations, but for families, for hospices, for home health agencies. We've had world congresses. We've had a number of presenters at our world congresses over the years who share a model of care similar to what you heard Tara describe and similar to what you're going to hear me talk a little bit more about. And those countries include, just to give you a flavor of who's talking about this model of care, Singapore, the Philippines, Russia, Italy, Portugal, Kuwait, Africa. It is truly a worldwide recognition of the need to provide the appropriate type of care on a continuum for these children and their families. We also do advocacy on behalf of families, and we do a lot of education for physicians and provider groups and even health insurance organization. But really what ChiPACC has focused on in the past few years, actually more than 15, is this model called ChiPACC. And this is important for many, many reasons. I'm not going to tell you anything you don't already know, because we already know that the current delivery systems for these children and their families do not adequately address the needs of children with life-threatening illnesses. And what Tara talked about a little bit was, their work with the Medicaid agencies in their state and in their service area, the tri-state area, and the need and the efforts that they as a provider have had to expend to educate state Medicaid agencies about provisions of care that are already available for these children and their families under 2302, which was huge. That was a massive step forward. That as far as state Medicaid agencies are concerned, they have huge, huge responsibilities and huge spans of control over service delivery and individuals they serve. So how does this change come about? Because what we're faced with is the definition of hospice from 1965 and the reality that for children with life-threatening illnesses, that does not work. 6 months or less is too limiting for a standard of care and a provision of care. So let's talk a little bit from a macro level. What does Medicaid do? Medicaid is a joint federal partnership where if the Medicaid agency agrees to follow certain federal rules, the federal government will help share in the cost of those services. What's important about this relationship, and we're not limiting ourselves to just the Medicaid agency, but what we find is that private indemnity plans also take their cue from what the federal law and federal programs look like. So the impact of a change in law is far-reaching, and Tara talked about that as far as knowing that when they have their concurrent programs at the 6 month or less expectancy, the education of providers in the state, and now knowing that it's okay to have some type of palliative care to go with the hospice care. So Medicaid is important as far as setting a tone, that federal law. States, if they agree to provide services to what is defined in law to people who are eligible, and a discrete set of services that are defined in law, and those are the minimum, then they can have a Medicaid program. After that, the law gets pretty big. And what the law says is you've got options and you've got choices. And those options and those choices indicate to what degree a state may want to expand their Medicaid program. The state at that point has the option of maybe not doing it statewide for a number of reasons. Maybe it's because they don't have a provider network sufficiently big enough to provide that service throughout the entire state. Or maybe they have a critical need in a particular geographic area. So they have a lot of flexibility regarding these additional services they can provide. But wait, there's more. In addition to providing those additional services, they also have the opportunity to provide waivers where instead of institutional care, they can provide services in the community. And those services have a pretty long arm as far as definition. It allows the state to say, this is what is needed in the community to preclude the institutionalization of a person. So it allows for some very creative resources and delivery system models. But there's a little catch there. That person must meet an institutional level of care. There's also the demonstration programs where a state can come in and say, we have a better idea than you and we want to test it. And those particular programs may completely revamp what their state Medicaid program might look like for a particular target population or a particular disease. These are all testing models, and from these testing models is where changes in law can occur. States are also, with these particular waiver and demonstration programs, time limited. They're incredibly administratively burdensome because the state either has to show that it is cost effective or budget neutral. So there's a lot of parameters built into what those programs can look like. Not conducive to being something states are willing to do. So a parent should never have to choose between hospice care and hope for a cure. With that said, we have moved on to the ChiPACC model. And what is the ChiPACC model? And I'll talk to you about that in a little more detail. Tara describes the components of section 2302, and I hate to sound so technical, but that was a huge provision of change in a law that had direct impact on children with life-threatening illnesses and their families. ChiPACC is 2302, removing that barrier of the 6-month limitation. It will allow for services to be provided from time of diagnosis with hope for a cure, which would include curative, social, and palliative care. It provides each enrolled child an individualized treatment plan that includes, manages, and coordinates services from providers across the healthcare spectrum. And it really addresses the need to provide services in the most appropriate setting based on family choice rather than the funding stream. In looking at what does this program provide, you're not really going to see much different here than what Tara described, which is great news. They have done amazing work identifying the component parts of what does a concurrent palliative and hospice care program look like. The difference, the major difference, is that at point of diagnosis. So for example, we take our 5-year-old to the pediatrician and something doesn't seem quite right, so tests are run. The family is brought in with the 5-year-old because he happens to be with them. They receive a diagnosis of a type of leukemia that may be the onset for the actual symptoms. The severity of them will be protracted over time, over years. That of children, the number of children who could qualify for this type of delivery system model continues to increase. So what does the service model look like? Something that is discrete to this program is the use of a ChiPACC coordinator. This is actually a person within the state Medicaid agency or designee that would be responsible for overseeing that the ChiPACC program or programs, if there are more than one in each state, are being conducted in accordance with what the federal law says as far as provider services, quality control measures, and payment methodology. This is another area where Tara explained the type of individuals and disciplines that work to provide care to their children. This law would actually mandate that there be an interdisciplinary team approach that has, and the operative word here is at least one physician, one registered nurse, one social worker, pastoral counselor or other counselor, and one case manager. That does not preclude the ChiPACC program in that state from including more individuals on that team. The program must offer both curative and palliative care from point of diagnosis as needed by a care management plan. There is no longer, and I'm repeating myself, but that's important, there's no longer this requirement that there be this 6-month window before such care could be provided. It also takes into account care planning that suits the best interests of the family in the form of respite care, in the form of our other children in the family being affected by the diagnosis and treatment of the child with a life-threatening illness. So is family counseling, is child counseling for siblings something that needs to be done? This program would take that into account. As I mentioned earlier, under the Medicaid program, testing can lead to results And what we found is that there are 5 states who agreed to test the ChiPACC model. Florida, Colorado, New York, California, and North Dakota. What they found is that without access to the hospice and palliative care for these young children, the only remaining options for families were for them to seek oftentimes emergency medical treatment and costly hospitalizations. By using this interdisciplinary team approach, by starting the care coordination at point of diagnosis, they actually demonstrated some rather significant cost savings of between $1,700 and $1,800 per child per month, or more than $20,000 per child per year. That is a lot of money that can be redirected to providing care to more people and more services as needed to more people. So it was a huge, huge outcome and impact that these 5 states had in informing what the ChiPACC model looks like. One of the things that we have done, because we are a international organization, in our outreach to countries throughout the world, we do know that, as evidenced in our World Congress, this countries that presented models similar to this, that we continue to have current communications with countries in Europe and Asia, in the Middle East, looking for what is going to happen with the ChiPACC model. So we're pleased to hear that their interest continues and that our dialogue with them continues as well. This bill was reintroduced into Congress late this summer by Diana DeGette from Colorado and Michael McCall from Texas. And Diana is a Democrat and Michael is a Republican. It was introduced as a bipartisan bill. We are waiting for Congress to take action on our program. We are cautiously optimistic that this will pass. We today, and I'm very, very pleased to announce that the National Hospice and Palliative Care Organization put out a press release endorsing this program. And I'm ready to turn it back to Gabby for our question and answers and what's next.
Thanks, Terry. That was incredibly informative, and it's so great to understand the, the kind of the coming together of all of this and how that's happened. And thank you for all of your advocacy to get us closer to services that really think about these kids as a whole person and these families as a whole unit, and providing services that really meet the needs of just quality of life for these families. It's so critical. If anybody has any questions they want to put in, I've got a couple already, but we've got maybe just a few minutes here before we need to wrap up. And Tara, I don't know if you're still with us, but I think one of the biggest things that comes out of this for me is that, is that this is really, the big picture message is that hospice / palliative / comprehensive coordinated care is a part of healthcare. It is not like something for over there for later when the time is right. This is coordinated care. This is holistic care. This is a bonus on top of, getting medical care. This is like, let's think about everything together. And I think that the more that we all start thinking about this kind of care as care that we should all have access to for our families, the next question is how do we get it, right? And so that's the advocacy piece that we all have to think about. And Tara, I really appreciated you putting some of those questions out and Terry sharing some of these key points that we can refer people to say, listen, my kid is struggling. Our family is struggling. We need help. We should be able to get help, right? And I don't know if somebody's watching, I won't say North Dakota, because clearly they already, have some skin in the game here. But if somebody lives in, rural Colorado or, rural Alabama, and they're feeling this stretch, I mean, what do they do? Is it a matter of time before we start to just see these services, filter out throughout the country and the world so that they're accessible on a, more universal basis?
Well, my response to that would be, there is nothing today that precludes a state from, through a waiver or a demonstration program, creating this delivery model because of the administrative burden and the resources that it takes. There is not an incentive for them to do so. By creating a program that is a state plan option that does not require any additional administrative burden for accounting and data points, it makes it much easier for a state to say, that's a great idea, I can do that. The other piece to that is, demonstrations and waivers can be time limited. That also can be a disincentive to states, like, I'm going to set this up, and then there may come a point in time where I'm not permitted to do it anymore. So by taking the testing aspect out of it and creating it as a recognized delivery system model, changes everything for a state to be able to implement. It makes it clear what their responsibilities are, what their obligations are, and it's much more user-friendly. The piece that becomes the advocacy piece once the legislation is passed is, one, encouraging states to do it, and two, looking at when they elect to do this, where do they do it? Is it broad enough and in the correct places within the state, if not statewide? And states can be resource challenged because the federal law will say, if you're going to have this program, then you have to provide these services that we are prescribing for you. If the geographic region can't do that, then that may be a reason, and a very good one, because we want to make sure that there's quality of care, that a state may choose to do it in a more metropolitan area than a rural area. Telemedicine has come a long way in improving that and minimizing that being rural as a barrier as well. So.
Right.
Yeah, I wanted to say about the rural piece, that's something that we have done also. We provided telemedicine. We have these HRS systems that monitor basic vitals and our communication tool. So even for our children who are way out in Loudoun County, we may not be able to get an after hours nurse to them within 2 hours, but we can we can look at their vitals. Anyway, what I'm saying is, that's one of the things that we've tried to do. But if there was a way for the states to automatically adopt this ChiPACC, it would save us all so much. And we're always a little bit nervous about that 6-month, term. And we just keep moving forward, and having relationships with Medicaid is how we've been getting around that and able to actually push through, because they see the benefit of our care. Right. And the DC Medicaid director in particular says, since they have come onto your service, they have been out of the hospital this whole year. And that's real dollars and cents. And if that's the only way that we can appeal to the federal government and to states, then so be it. And we've got that data to show that as well.
Yeah, it's absolutely huge as far as the cost savings. But it's not just about the cost savings. First and foremost, it's about the quality of care. The reason that these children and their families are doing better is because they're getting the services that they need at the time that they need them. So by having the ChiPACC model, which removes the additional, removes that 6-month requirement, and says from day of diagnosis, all of this can happen is masterfully huge. So we're hopeful.
Yeah, no, it's amazing. And I think, anything that we can put out there for families and groups to better understand how to advocate for ChiPACC with their, their state level leaders, we'll put that out there and are happy to help shepherd
Awesome.
that through with as many groups and families as possible, because it would be a game changer, and I think, Tara, it brought me to tears when you were talking about that, that you provide these services to any family, no matter whether they can afford them, whether they have, insurance or not, because I have felt so privileged with that we've been able to get these services, and these are not services that should be available to people who are loud enough, who can advocate, who have good health care, who have, every family that's dealing with a child who has, medical complexity on the level that our kids do. We absolutely deserve this kind of support and relief. I think what we have to be doing is shouting at every, turn, like, we need this, help me get set up with it. Right. And I think that, sadly, with a lot of things, it has to start with families kind of screaming about it loud enough so that people hear and saying, this is something we need and we want, and help us get set up with it.
Yeah, and I think that, organizations like Capital Caring Kids and others in our Pediatric Alliance for the Mid-Atlantic region, we need to work more closely with Tripac and find out what we need to do to lobby our own representatives to make sure that this bill is passed and brought to the table and that awareness is created. And that's something that, we've worked on in fits and starts. And when Concurrent Care, the Affordable Care Act was threatened, we did a whole lot of responsive work to that, and everyone was really excited about it. But then once, the Affordable Care Act seemed like it was going to stay in place, everyone kind of quit, and then of course COVID happened. But I really believe that our responsibility as an organization is to work closely with ChiPACC and also with our families to create a wonderful pathway and an easier way to lobby for these services so that we can create greater access for all children, no matter what phase and their illness is in at the moment.
Yeah. And there's so much work to do. I did work in Eastern Africa for many, many years. And I think about how they don't even have access to morphine. And, it's just the basic needs that really we have to get down to really make these services available on a wider scale. There's a lot of work to do, but I think, like I said before, it ends up being, laid at the feet of these families to advocate, educate providers. Are there resources that we can send providers to if we say, my kid needs more support, we need more help? Where do we send them if they don't get it? If they don't know how to get our kids signed up with palliative care or, some better services? Is there a place where we can send a doctor so that they can read it and say, oh, okay, I get it?
Mm-hmm. Well, if it's a doctor in our region, we are happy to connect with them, and just providing our brochure is really, you probably even haven't even seen it, Gabby, because you didn't need it. You were on service long before we developed it, but it really does clearly define concurrent care and who's eligible and how to access the care. So that's something that Allison and I are working on now that COVID has sort of released its grip from our team, is, increasing that awareness across all of the specialty clinics at Children's National and Inova, so that those people understand who we are and what we do. Because even though, we'll send them things, it's more about building those relationships for them to understand what we do. And so if we have a patient and their family who's saying, hey, I'm wondering about this, that's a great way to connect and allow the specialists to understand the breadth of our services.
And the same with Children's Hospice International. We're an advocacy organization, we're an educator, we're a teaching organization. Our phone number, our website are certainly avenues for direction of and redirection to providers to get answers and to have an understanding. It is amazing how many even pediatricians don't fully understand this concept of coordinated end-of-life care or care for children with life-threatening illnesses. And I use both of those phrases deliberately because that's not what they train to do. They train to heal and cure. And this creates an emotional challenge for them. But yes, that's what we're there for too as well. And we welcome those kinds of conversations to advance the understanding and to try to resolve and figure out what are the resources that are available to individuals in their area.
Right. And it puts those healthcare providers out of their comfort zone. But frankly, all of us families are out of our comfort zone too, right? So it's like, these are discussions we need to be having jointly. And yeah, no, I think that's wonderful. And Tara will happily put a copy of your brochure, up for people, because I'm sure it applies anywhere, people can use those arguments, right?
Absolutely. And I think any pediatric hospice organization follows the same guidelines. We kind of work together on our communication. The other thing that we do is we do a lot of education at the different hospitals, a ton beyond LNEC pediatric training. We do a lot of, training on how to have difficult conversations, how to sort of, I think someone used this term and I don't like it, but man up and actually be able to face, number one, your patient's mortality and be able to be brave enough to have that conversation with the family in an honest way. And so that they can get the support that they need. So we do a lot of that throughout the year. So if we can have more families who want to come and talk about the services, that helps as well. Gabby, you're a great advocate for us and you've done some video work for us, and we want to share even this training on our website, and so that not only our staff across the organization have a better understanding of concurrent care and how pediatric hospice works, but for those who are really kind of maybe seeking this out, to hear straight from you the benefits of it is so powerful.
Absolutely.
And then Terry talking about the global efforts. I mean, that's where my heart just like starts to pound, and I get so excited about what the future of this is going to mean for all of us and really dedicating our time to this. Terry, I am so impressed with ChiPACC, and I've been stalking your website for years now, but it's so nice to meet someone on the board and see this work that's being done by such compassionate individuals. It's really exciting to see this, and I'm so glad that we were a part of it today.
Yeah, well, thank you. And you too, great job. So impressed.
And we'll be continuing this conversation. I think that, we'll put this up in our resource center and families can access it, but I think there'll be ongoing conversations and ongoing opportunities to share more about ChiPACC, more about, how to advocate and to get the care that our families deserve, and yes, Tara, that haircut night was so amazing here. I still have the braid of Elliot's hair is like this.
I wanted to go find that picture.
Yeah, it was amazing. And we even got some beautiful birthday cakes. I mean, hospice really is about taking care of the family and feeling loved and feeling human. I mean, we feel so isolated and so, it's just so life-changing to have this kind of experience with your child, and it brings back a little of the humanity and the, to our lives. So, we're really grateful for the conversation today. Like I said, I hope it's just the beginning and we continue to talk about ways that we can get families advocating, get families signed up, help find some relief for families around the world who are dealing with more than we ever thought we would ever have to with our children. So I thank you both so much, and the organizations that you work with and all of the efforts that you guys are taking on to help our families. So we'll talk again soon, but thank you everybody. And we'll, yeah, thank you.
Thank you so much. Have
Bye,
a good
everyone.
night. Bye-bye.
Bye-bye.